And I am sitting in for Tashana Johnson, who unfortunately was not able to join us today. Many of you probably have met Tashana. She is the Community Outreach Manager for the Lynchburg office. And if you wouldn't mind taking a second to please enter your name and your organization in the chat so that we can see who has joined us today. And also please click Speaker View at the top right of your screen instead of Gallery View, which is the default. And you can utilize the chat feature for any questions or comments. I would like to introduce you to Dr. Sean Ryan, one of our founders and chief medical officers, and our chief medical officer, and Dr. Nav Kang, our chief clinical officer.
Hi, thank you. As you can see on the screen, I'm Dr. Sean Ryan. I'm one of the founders of BrightView Health. I'm a board-certified emergency and addiction physician, and founded the organization years ago now with some pretty core tenets and primary mission and vision of doing good evidence-based, science-focused addiction care and bringing compassionate treatment to folks when they need it, as fast as we possibly could. We're going to talk a lot more about that simple, what sounds like a simple couple lines and a couple of sentences. But that's really what we've done for these many years that we've been working throughout the kind of eastern half of the United States at this point, and continue to find the need to grow into communities like Lynchburg so that we can meet the needs of the community members there with substance use disorder issues. Dr. Kang.
Thanks, Dr. Ryan. Good afternoon, everyone. Yeah, thanks for joining us this afternoon. We're very excited for today's discussion. I'll say to Laura's point, if you have questions, please do throw them into the chat. We've received a few questions during the registration process, and we'll knock those out towards the end. But if you all throw questions in as we go, we're happy to address them along the way. And if you prefer to hold them towards the end, that's also fine. We'll have some question and answer time. But I'm Nav Kang. I'm a psychologist by training. So I trained as a therapist. Spent many years working for Bon Secours Mercy Health, leading behavioral health services through a large part of Ohio. Met Dr. Ryan along the way as we were endeavoring to respond with more clinical acumen to patients with substance use disorder. And I guess the rest is somewhat history for us. So you'll hear from us about how proud we are of the services that we offer, just the level of service we're able to offer patients in terms of our comprehensive treatment program. But ultimately, what I hope you all take away from today is also a sense of how important it is for us to have connections like this, for us to have relationships with folks such as yourselves. You can look through the chat already and just see the diverse stakeholder group that's been assembled today. And I think all of us appreciate how complex substance use disorder is, how complex our patients' lives are. And so it's critical for us to be partnered effectively if we're going to ultimately make the type of success that we want to achieve at the community level. So again, please put your name and organization and other information in the chat. Hopefully today is the beginning of a lengthier discussion. I think many of you have met Tashana and know some of us already, but hopefully we use this as a pivot point to ensure that our relationships deepen, because the better we collaborate, the more effective we can be for the folks that we mutually serve. So thank you for joining us today.
Thank you. The Lynchburg location opened on December 21st of last year, and we currently have 55 sites across Ohio, Kentucky, Virginia, and Delaware. And I am excited for our time together today, not only to showcase our facility, but more importantly, for you to virtually meet from two of our leaders, Dr. Ryan and Dr. Kang. And BrightView is looking forward to providing patient-focused quality care to the community. And during this open house, Dr. Ryan and Dr. Kang will talk about medical excellence, clinical excellence, and treatment innovation.
Thank you. So we're going to start with this slide because this is really the reason that BrightView exists, to be honest. Many years ago, practicing an emergency physician here in Cincinnati, This is exactly what I saw as the primary problem related to how we are treating patients with substance use disorder and related mental health issues. Somebody would show up in the emergency department. We would do some minimal services for them, if any, which was unfortunate and inappropriate, but we'll talk about that a little bit more later. And then we would give them a pamphlet and we would say, hey, good luck, you should stop drinking or doing opioids, or whatever their drug was chosen for that time. And then they would come back because nothing happened when they were out in public. Very few folks still get treatment. So as I'm sure many folks know, only 1 in 10, maybe 1 in 5 individuals in any community really gets good substance use disorder treatment that's effective and timely. And so they would do this cycle in front of us until, especially with opioids, often in the emergency department, the outcome was fatal. They would come in 2 or 3 times, sometimes in a day, in a week, and we would maybe refer them to someone who they wouldn't see. And they would, relapse or continue. And with opioids, like I said, that was where it really struck a chord with a lot of us. And many of us had friends and family affected, me included, that had friends and family affected, and drove some of my decision to dive into the field. And my frustration as a high functioning emergency physician was this circle or this spiral. We probably should modify the graphic to show a little bit more of a downward trend, because that's what happened. And that's why we, started BrightView. I was a frustrated emergency physician. I had a friend working in social services and kind of adolescent housing issues for indigent, and an attorney and a very bright individual that I knew, who's our CEO currently, original CEO and still is, Chad Smith. And we presented this issue, and I decided it was unacceptable. And so we're going to talk about what we've decided to do over the past many years. I guess 7 or 8 years at this point. We've been working on disrupting this spiral downwards. Next slide, please. A little bit more about what we've done about that. So BrightView Health, and we'll talk about our part of the Continuum, focuses on kind of acute transitions and then management from intensive outpatient on through for years for some folks, if that's necessary. But that is not by any stretch the whole continuum. It's not the whole list of things that's necessary. And we talk a lot about partnership. We'll talk a lot today about partnership with the community and how we manage these things, because this is a community disease. I've never seen another disease, and I lost my mom when I was younger to cancer. I've never seen anything affect a more broad swath of individuals than addiction, related to the friends, family, and community, and the damage that the addiction does for an individual and their related friends and family and such. And so, it really does require an ecosystem. I think we're really good at what we do. I think we probably actually are the best at the biopsychosocial outpatient model we're going to talk about today. But if we don't have engagement from we don't run emergency departments, even though I came from there, and we have done a lot of partnerships and can talk about our emergency acute care transitions model, but we don't run those. And so we need emergency departments to participate. Intensive detox facilities, residential, other social support services that we don't provide. Those are parts of the ecosystem that's necessary to get people into long-term recovery at a highly successful rate. You see some of the stats here. These are programs that we've worked with, or individuals I know that have done these studies. And they basically, by and large, say, very few Americans are getting the right care, especially once they're identified in the healthcare setting, which is pretty upsetting. I attribute to everybody that folks are showing up 1, 2, 10, 20 times in a healthcare setting and are getting no help, and often have a fatal outcome. And we don't accept that in the United States as a reasonable outcome. If you go to the emergency department, you should get pretty good care and have some measure of follow-up. The current widespread model isn't working. I don't think it's lost in anybody that looks at the CDC data. They obviously, a lot of the CDC focus has been on the COVID epidemic for quite some time, but they have not lost track of the fact that it's gotten worse and worse over COVID, which is a different discussion to have at another time. We also know that many of our patients face external challenges, and that's why we really do try to provide a holistic wraparound model. But again, goes back to the need to partner with their primary care physician, the hospital, their psychiatrist, if they're not seeing one through us, all these things, transportation as an example. All these things are issues for our patients and are documented over decades as primary barriers to folks getting into good recovery from substance use disorder. Not novel today. I will say, unfortunately, COVID has made all of those things worse. So anytime I've ever asked about COVID, why is the mortality? Why are we seeing the numbers get worse? The answer to me is pretty simple. We had a long list of barriers that we try to reduce for our patients at BrightView Health. Every one of those things got worse with COVID, with the exception of telehealth, which we can talk a little bit about. So really disrupting this cycle takes an ecosystem, it takes a community, it takes a continuum. And there's a lot of challenges that continuum, that partnership, those community relationships have to address to have a high chance of recovery from substance use disorder. Next slide. Lastly, I'll just finish with these bullet points, which is some of the ways that we have disrupted the cycle other than partnership, but some of us specific, something specific to BrightView. We do systematically identify, both through the literature and patient interviews and experience of our providers, the problems that patients have that we can deconstruct or surmount those barriers. And they include things like taking every insurance or no insurance. We take all of them as to the best of our abilities. We really do no wait list, which I think years ago when we started BrightView Health was a very foreign concept to folks with substance use disorder or mental health. In fact, the norm, Dr. Kang can probably echo this, the norm is wait list. That is the expected situation for somebody. And for me, as an emergency physician, we obviously have no ability to have wait lists because we're not allowed to legally. But that was just really at odds with the understanding of a disease, especially for opioid use disorder, which can be fatal today. So wait list, disease fatal today, those things don't go together, never have for us. That's why we have a 24/7 call center. It's why we take walk-ins. It's why we do medications same day if they're indicated to prevent people from going back out to use, which was not a thing in most places when I started in the field. And we really do stand by the concept that if you want help, you can get it today at BrightView. And we're by no means perfect, but I think we have a pretty long multi-year track record of doing it that way and making sure people got the help they needed as fast as possible. And I'm happy to say, like I said, I think that's changed over almost the past decade, where it was such a foreign concept then, and now is becoming an expectation, at least in opioid use disorder treatment, where you're seeing folks really move towards that model, and we're proud of that. Next slide. Dr. Kang.
Thanks, Dr. Ryan. To clarify that, and I think this slide here is meant to predict into some questions and to just provide crystal clarity on what Dr. Ryan just stated, right? We've got a trend in this country of folks presenting with a life-threatening condition and then having to wait for services. To put a number to that, the average wait time in many parts of the Midwest was over 50 days just a couple of years ago. Think about that then, right? So someone with an urgent life-threatening condition being told to wait 2 months to receive care. It's not acceptable in any other disease state or any other area of healthcare in this country, and yet somehow that continues to be the norm as it pertains to substance use disorder, and specifically to opioid use disorder. And so when we say treatment on demand and comprehensive treatment on demand, it's important to understand the level of service that we offer is that same day, next day access to care, right? And so folks can schedule online and call our call center, but as Dr. Ryan said, folks can just walk in unannounced, and our team will take care of them and ensure that their needs are met. Many times we'll see folks the next day, right? So when you think about it that way, when we staff and invest and train and develop our teams and cultivate that culture, that sense of urgency that we're talking about, that emergency room surge mentality that Dr. Ryan brought and continues to infuse our practice every day across the BrightView system, you can actually have quite a robust level of service in an outpatient setting. And so we operate as an outpatient service provider. We also have the ability to provide intensive outpatient services, which for those who are less familiar, IOP is effectively a high dose of group counseling to initiate treatment. So someone is coming in typically 3 times a week for 3 hours of group therapy, in addition to the other services that they're receiving. And that can go for a month, 2 months, 3 months. So you can see it's very high dose of counseling. It's a very effective way to jumpstart treatment for folks who have a slightly more intense need. It is quite intensive, as the acronym would say. And so we don't operate overnight stay. We don't operate residential facilities yet, although that is something that we explore and we'll be looking to potentially offer over the coming couple of years. We work very closely with our acute care, our hospital partners. That's not just in the emergency room as it pertains to standing up clinical protocols for the effective management of patients with substance use disorder in the emergency room setting, but it's also about, hey, if we don't have adequate acute withdrawal management or detox capacity in a given community, there's typically a way to buffer that gap by using existing hospital capacity. In other words, like in a typical medical surgical unit, a standard hospital room, where a patient is treated one day for a cardiac illness and someone else is in there the next day recovering from a surgery, we can have a patient in there who's also being compassionately managed through the withdrawal process for their substance use disorder, right? It's really just about training for the physicians and nurses who are on staff there. And BrightView has done a lot, I think, to add to the literature, add to the toolkits, add to the education that have been adopted by some of our state partners as well, actually, the things that we've co-authored. And so would invite folks in Lynchburg, folks, if you know folks within the acute care system who are wanting to adopt those kinds of protocols, we would like to help with that. So through that effective partnering, you can build a comprehensive continuum of care, and you can do so quickly without having to build out new physical plant and without having to build a new hospital, right? There's frankly not enough money in the world to build enough detox hospitals to meet the need. And it doesn't happen overnight. Building a hospital takes many times years. And that doesn't reflect the understanding that we have of substance use disorder as a chronic, relapsing, oftentimes lethal medical condition, right? That sense of urgency has to be infused through this. So we have brought that treatment on demand, ambulatory service, outpatient service model of care to the table because we know the need is that urgent, right? And as we grow and as we establish our footprint in the community, then expanding into some other areas becomes an interesting opportunity and an interesting discussion to have. Like, should we offer psychiatric services? Probably yes, right? Should we look at recovery housing? If there's not enough, sure, something to explore. What we know is that comprehensive continuum is necessary because just like with any other disease state, you've got times where folks are sicker, they need more urgent help, they need to be monitored 24/7. And that's necessary for some percent of people, but it's less than 20%. Most patients are going to need outpatient care, and that's all they're going to need. And frankly, everyone is going to need outpatient care, whether they go to the hospital or a residential facility or not. Because think about it, any other disease state, we don't cure it or manage it in the long term from a hospital bed, right? That's for an acute exacerbation, a few hours in the ED, a few days in the hospital. Ultimately, though, the long-term work is done in the community, close to home, with treatment that's accessible and fits into folks' lives, right? Fits into their work schedule, their family schedule, and is convenient for them to access where they live. Next slide, please. Throw it over to Dr. Ryan to talk about our medical team a little bit, and then I'll share a little bit about our clinical services.
Yes, Dr. King. So as previously alluded to, I spent a fair number of years at academic emergency medicine program at the University of Cincinnati, where I originally trained. And one of the key focuses there in being a top academic emergency program is focus on medical best practices, evidence bases, science, and really adhering to the standards that are appropriate for any disease state. So if you go to the University of Cincinnati and you have a head trauma or a blood clot in your lung or whatever, you will receive phenomenal emergency care because of the network and the focus there on that issue. And in looking at this field for years, and it's unfortunately hasn't changed a ton at a national scale, that's still not the case, for addiction treatment. I think we've brought things a long way, but we have a much longer way to go. And for me, that is an unacceptable gap, was an unacceptable gap. And it still grates on my Hippocratic oath to know that you can get such phenomenal emergency care in a place. And again, most interestingly, you will get pretty much that same care in almost any city in the United States within reason. And in this field, just not that. It's just not the situation. That being said, there is plenty of literature, evidence, publications, and medical best practices out there about what to do. We're just not doing it as a country and as communities. And that is not because of a lack of things published to inform us. What am I referring to is things like the Surgeon General's report, which I was fortunate enough to participate in and be released in 2016, which now is 6 years ago. It's a pretty long time. This report was very many, hundreds of pages of the best practices and understanding of evidence for every use disorder, including alcohol, opioid, et cetera, and very clearly laid out stuff that we had fortunately already knew for years before that. It just hadn't been called out in such an extensive and national publication in, I think, 30 years prior to that. And it talks about things like medication for opioid use disorder, as an example. This is not a debate. I used to tell Dr. King, I would joke, like I would debate this with anyone, but I don't want to anymore because I've spent thousands of hours talking about it. And it's like saying aspirin is good for for coronary issues. Nobody goes, nah, I don't really believe that, or that doesn't make any sense, or my mom told me that doesn't work, or whatever. That doesn't even come up. It's just a known fact. And at this point, with decades of literature, hundreds of thousands of people doing better on medications for opioid use disorder than not by a lot. Like the gap is really big. We really shouldn't have to have this debate anymore, and yet still we do. And I call that Surgeon General's report out because it's just one of many, many things that we know guide how we should practice best and guide how BrightView does things. So if you think about our three-part model, the biopsychosocial is the quick word, but the medical, psychological, and social components of treatment. We are very fortunate to have a large network of board-certified addiction specialists and psychiatrists and nurse practitioners and PAs who are all working together to really keep a pretty tight lane on how we do our medical component of that treatment. And I think that's pretty unique in the country, most likely. Not really run across that. I do a lot of national and federal work for the American Society of Addiction Medicine, and I'm not sure of any other group that has such a tight parameter. It's generally folks who are just like that physician is working at that opioid treatment program, and they can do mostly what they want within the boundaries of federal rules. And that's not how we approach it. We very intentionally use our hundreds of years of collective experience in addiction treatment to make sure that we are appropriately selecting and dosing the right medications, that we're keeping on top of things like what's the best new treatment for stimulant use disorder, which is always a hot topic now. It has been for years, but it's kind of resurfaced more. And then, what's the right best dosing for each individual patient versus the group? How is that affecting retention in the programming? We talk about all this stuff constantly. We have a lot of spreadsheets and dashboards and regular meetings about this stuff. And I'm here to tell you that is a unique strategy for an addiction network like ours. So I say all that to say when folks have questions about how committed or intentional BrightView is about medications, and I've heard every version of it. You use too much of this, or you think that, whatever this dosing. And all I ask folks to say when they look at our system is please understand there are thousands of hours a year that go into just making sure we're doing the right best thing for each individual patient on their medication dosing choices, et cetera. And that is a physician-patient relationship that should be respected, given the intentionality of how we go about choosing those medications, whether they be methadone, buprenorphine, Vivitrol, other medications. Almost none of our patients are on a single medication. That's just, they have complex overlying other issues. No, we don't try to provide primary care, but I'm not going to let somebody's hypertension remain out of control for the 2 months while they're trying to get into primary care. It's just not going to happen. And so we're very blessed to have a lot of double and triple boarded addictions physicians and other practitioners, a lot of great nurse practitioners, et cetera, who are capable of managing what are generally a disastrous medical situation when patients show up. I'll finish by saying not many patients show up with, phenomenally managed diabetes while also doing injection opioids. That is not a thing. And so we really do try to get people rapidly on the right path, and we are extraordinarily thoughtful about the medications we choose for our patients and the other medical treatments that we select. Dr. Kane.
Thanks, Dr. Ryan. And I think many of the things that he just laid out, we expect in other areas of healthcare, right? That there are clinical guidelines, that there are practice algorithms and clinical decision support tools, we call them. In other words, just effectively using data and electronic health records to guide our practice, right? So we spend a considerable amount of effort to infuse our practice with that data and provide feedback and transparency to our providers such that they stay within those best practice recommendations that the literature puts forth for us and that we contribute to as well as an organization. As Dr. Ryan said, hundreds of years of experience collectively on the medical team. I think on the clinical team, we can say thousands of years of experience. There's just more of us. And so we can claim a larger number of years there. But as it pertains to our psychosocial services, right? Overall biopsychosocial model, which means that we interpret that there are biological, psychological, and social risk and protective factors for developing a substance use disorder. Okay, that's how the patient got to us. The treatment should then also reflect that understanding. It should have a medical component, as Dr. Ryan just walked us through. It should also have a psychosocial set of components, right? And so when we talk about psychotherapy or counseling services, we're talking about individual counseling, group therapy, family therapy. Not always accessible. It may not be something that a patient is ready for right out of the gate, but certainly we find from many patients that the family interventions, whether it's education or therapy, are actually some of the most impactful interventions that we offer patients in the long term, right? And given the transformative impact that can have on their relationships and what have you. From a social services or wraparound standpoint, it's very difficult to make some of the long-term gains for patients if we don't effectively address social determinants of health or social drivers of health, right? So if someone doesn't have a safe place to go tonight, it's going to be an unstable situation here in the next 24 hours, right? We have to take that seriously. We have to get to work on that today. And it starts with just asking, do you have a place to go tonight? Do you have a way to get back here tomorrow? And when I say that sometimes a patient may return the next day, I very literally mean that the patient may return the next day. The complexity that Dr. Ryan just described means that many of our patients need to be seen relatively quickly on a turnaround basis to make sure that they're safe, they're stable, and that they're safe. And so our entire team will see the patient again the next day, very next day, very literally, right? Again, I find that sometimes it's important for us to be crystal clear about the level of service that we're able to offer patients because it is still atypical. Since the norm in this country continues to be that folks are on wait lists, the fact that we see folks on demand and that is not some artificial intake-driven philosophy, but instead we can see the patient again the next day by that entire team. And sometimes even the next day, 3 days in a row for some patients. It depends on how sick they are, right? That's the level of service that we're able to offer. That's the level of investment that we have put into staffing and training our teams appropriately. Well, when we think about social services or social drivers of health, our care coordinators drive a lot of that service. So meeting with patients regularly, typically when they come in for their other visits, the care coordinator is also meeting with the patient. But the essential piece of care coordination is the coordination aspect, right? The multidisciplinary team actually having a sense of cohesion and an intentional approach to wrapping around that patient. To Dr. Ryan's point, the typical practice in addiction medicine, unfortunately, at many places is that the doc is down there doing whatever they're doing and the rest of the team is over here doing whatever they're doing. Instead, we don't think of ourselves as a counseling practice. We don't think of ourselves as a doctor's office. We're an integrated addiction treatment service. And so that means our team actually has to talk to each other. They have to have a treatment team. And that happens on a structured basis as well as on an ad hoc basis. And our team, our clinical team, is supervised at each of our sites by an independently licensed master's degree clinical supervisor, who themselves is supported by myself and others on our clinical leadership team who offer supervision, investment in our staff in terms of building their skill set for assessment and intervention and therapy skills and everything along those lines. So pretty comprehensive model. Quick note on harm reduction. We'll talk about our outcomes and how our treatment program is effective. So harm reduction means a lot of different things to different folks. What I just want to reference is how we practice, how we utilize harm reduction inside of the BrightView practice, right? So we operate using what's called a non-punitive harm reductionist clinical philosophy. It's a fancy way of saying we don't fire patients from treatment for struggling with the condition for which they were seeking our help, right? Again, we don't do that in any other area of healthcare. I used to work in the emergency room as well. We used to treat patients all the time who were brought in after having been smoking a cigarette, walking in, looking for treatment for COPD exacerbation. We would take great care of folks under those circumstances, right? And by the way, tobacco use is a substance use disorder, right? And so when it comes to patients with opioid use, alcohol use, the norm is actually that if patients relapse, continue to use, whatever it might be, they're characterized as not being motivated, not being serious about change, not wanting treatment, and they could get dismissed. We don't do that in other areas of healthcare. If I go to a primary care provider for diabetes care management, I don't expect them to call my blood dirty and then to kick me out if I'm not making the lifestyle changes that they've recommended, diet, exercise, whatever it might be. Instead, a typical primary care office would interpret my struggle or my lack of change or progress as me needing more support, more resources. I used to work in primary care as well, so I know that is how they operate. And they would actually probably have you see someone like me under that circumstance, right? The psychologist can help build goals and make progress towards chronic health condition treatment plans, as well as depression, anxiety, and that kind of thing. So that's the framework we use here at BrightView. When our patients are struggling, if they're not making the progress that they want to be making, then we interpret that as them needing more support, more creativity from our side. The therapeutic alliance then is essential to having a relationship like that with our patients. We don't want it to be adversarial. It's not two sides of the table from which we're arguing or something like that. We're working together on a collective journey. If we look at the next slide, you might wonder, okay, is this effective? Have we measured that? Yes, we use a measurement-based care program at BrightView, which means that we do measure how our patients are doing in a variety of ways. We use that measurement to inform our practice at the patient level and at the programmatic level. So we can know if a patient is feeling more or less depressed or anxious, or what their urine toxicology results are indicating, or does their blood work indicate that they need a referral to a specialty provider type to address some other issue that is outside of our scope, needs to go to a different provider for that. And so we've published these results. The research is available on our website. To give you a broad view of it, because I'm not going to read the slide to you, we're talking 12,000 patients studied over a period of almost 3 years. And what we found is that there is a tremendous relationship between engaging in the BrightView program and meeting your goals as a patient. For the data nerds out there, this is statistical analysis. We're talking p-values with 14 zeros. So pretty strong relationship when we think about extremely statistically significant results, to use the technical terminology. So yeah, patients are less depressed, they're less anxious, they're sleeping better at night. They're using the hospital emergency room and inpatient space less for medical, for psychiatric reasons, and for substance use. They're getting disengaged from the justice system, less arrests, less time in jail, getting their kids back, getting off probation. Folks are working, some for the first time ever. That takes a little bit longer, as you can probably imagine. If someone comes in really sick and there's a lot of other things going on, we're working on some more basic stabilization, as I mentioned earlier. It could be, housing, food, transportation kind of stuff the first week or so, and then we build from there, right? Of course, I should reference that folks are using alcohol and other drugs less, right? We've used this feedback loop that we've created at the patient level to have those discussions with patients about where they're making progress, where we need to do additional work, where they need additional support. But then we've also taken this and fed it back into our treatment program that informs our treatment design, right? And we've been able to establish what is that minimum effectiveness threshold that patients need. How many visits of each type? How many times should you see your doctor? How many times should you see your counselor in the first month of treatment, the third month, the 6th month, the 10th month? We expect that kind of framework in every other area of healthcare. If you go to the doctor today and you get diagnosed with something, they can tell you what the typical treatment plan for most patients is going to be in order to achieve a benefit. They'll tell you, hey, if your situation is worse, or if you're sicker, or we find something else abnormal, you might need more services. But there's a certain threshold under which they don't recommend that you go for any other condition, right? That transparency, that clarity is something we seek to offer to our patients as well. And we've used this large data set that we've compiled over the years to create that framework, which is very compelling. Again, research available on our website. Happy to discuss with folks who are interested at a later date. I'll pass it over to Laura. Next slide, we'll talk a little bit about feedback and just the importance, again, of the relationships that we have and the ability for all of us to communicate back and forth. That's how we have grown. That's how we have gotten better in our practice, is by having open dialogue with folks such as you all who have made some time out of your day to join us. So Laura, I'll throw it over to you.
Thank you, Dr. King and Dr. Ryan. So yes, as Dr. King said, we do value your feedback. It helps us assess how well we're doing, and it's a critical resource for us to improve our relationship and services. Please feel free to put any questions or comments in the chat, and we'll get back to them at the end of the slideshow. But we would now like to take you on a brief tour of our site. What you're seeing is what our patients see, our facility from the outside. We are proud to provide a clean and welcoming environment where our patients are treated with dignity and respect. So right here, you're seeing the exterior of the building, and then our waiting room and lobby, where our patient service representative gets patients checked in and ready to see the providers. And this is our nurses station and medical work area. Here is where our medical team begins the medical intake process and provides medical care. In the engagement room, our patients that can relax and watch television in between seeing their providers. We do provide light snacks and refreshments. And also shown are case management and counseling offices where our patients meet individually with staff. And pictured here is our group therapy room, where our counselors provide several groups each week. The OTP dispensing area is a service that will be available in the coming months. And this would be an area where medications for addiction treatment will be provided on site. So that concludes our BrightView tour in pictures. And in addition to providing a clean and bright treatment space, we do realize how important it is to make it easy to come and see us. We do have the 24/7 access line where somebody can call us up anytime and speak with a live individual. They can also go online. And we also welcome walk-ins until 3 p.m. every day during the week, Monday through Friday, offering treatment on demand with no wait list. And our goal is really to make it as easy as possible for patients to be seen. We believe that if someone wants treatment, they can get it today at BrightView. At this time, we'll take any questions from the chat and questions received during the registration. One of the questions from the registration that came through is, how does BrightView decide on a new location? And how does that process lead BrightView? How did that process lead BrightView to Lynchburg?
Yeah, great question, Laura. Like everything else, we use data to inform our practice, right? So some of it just starts with understanding where's the need, right? So public health data can be a useful guide to understand, what do local overdose rates look like, and then you can extrapolate what the mortality rate may be and that kind of thing as it pertains to opioid use disorder. And there's other publicly available public health data that provides us with information on emergency room runs and things like that. But a lot of that work is actually just done on the ground. So our team spends a fair amount of time in a community, up to 6 months before we think about coming to a given community, to get to know folks and understand what's the need here, and is there a level of service that meets that need already, right? Would BrightView be helpful? Can we fill an unmet gap? And so, we talked to Captain Green at the sheriff's office, just some of the stories around the number of deputies who are tied up on a daily basis as it pertains to emergency runs for substance use disorder. It's very compelling at the community level. We talked to Kelly adult probation. We talk to folks at the Parkview mission. We meet with folks, we spend time in community to understand like what are some of the trends. And we do spend time with public health as well. So it's not just like looking at the public health data, but let's get to know our colleagues in public health who are oftentimes then, facilitating, Narcan distribution or other, other efforts around harm reduction at the community level. Like I said, harm reduction means a lot of different things. So inside of BrightView, I gave you that description earlier. Outside of BrightView in the community, it can also mean other very salient things that are part of the national treatment plan that the ONDCP is putting forward. And so us getting to know the folks at public health, where have they met with success? What are some of their challenges? Again, spending time in the emergency room, spending time with folks who are typically interacting with our patients, whether it's within the justice system, the community at large, the existing healthcare infrastructure. That helps us to understand, like, would we be helpful? Who would we work with? And that is a lengthy process that helps us decide where we might go next.
Thank you, Dr. Kang. Another question is, what are your policies on sharing information with other community organizations? Do you have your own release, or will you accept releases of information from other groups?
Yeah, that's a great question. So typically releases from other groups are not compliant with what we need them to be, Suzanne. So addiction treatment provider, substance use disorder treatment specifically is required to achieve a level of privacy that exceeds HIPAA, typical healthcare. And so Part 2 compliant releases of information are typically not found in other settings. You all may have them at probation and parole, but typically what we'll do is ensure that our release is used, but let's make that as easy as possible, right? So in the case of probation and parole, the scenario that I can describe for you is that, a person may be in front of their probation officer in person or virtually nowadays. It happens a lot, right? So they could be having that meeting. That person, if they need addiction treatment, if they need to be referred to BrightView, that interaction between the probation officer and the person can end with the probation officer knowing where they're going, when they're going there, because we can schedule online or through the 24/7 call center, and with the release of information completed before they separate, because it's available digitally on our website. And so typically when there is a need to communicate back, that process can be truncated. And obviously we can complete that release of information when the person gets to us. But in that case, what's really cool for your team is that the officer knows this person's going to BrightView today or tomorrow. Here's the time that they're going. And I already know that the BrightView team can talk back to me and confirm that they made it and give me a diagnosis and everything else that is allowed on the release, which I think is a pretty nice scenario to be able to enact. So if you got someone in front of you today, you can make that happen where they end that interaction knowing where to go and when, but also that we can talk to you per those federal regulations.
Thank you, Dr. Kang. Another question is, with the prevalence of methamphetamine in Virginia, what does a treatment plan look like for a person in need of services for meth addiction?
I'll start to tackle this one with some follow-on from Dr. Kang. So in our mind, although substance use disorders can differ from chemical to chemical, they're generally approached the same way. We assess that patient's, again, 3-component need, biopsychosocial need. If there is a medical treatment available, which there are none FDA approved currently, and we're working on that with some different, I'm part of some research teams working on that. But there are some off-label medications we can use. But if there is a medical component that we can address, we will. That actually sometimes means we address a different mental health issue leading to the methamphetamine use, which is a little bit of a complex. It's never that clearly split, by the way, but can sometimes be, related. We may address something there, is otherwise leading them to the methamphetamine use, and therefore address the methamphetamine use medically. It's my truest hope that we'll find good FDA-approved, strong evidence supported medications in the next few years for methamphetamines. We should have already, but meaning we, the country, not we, BrightView Health. But that's just not the case. Not enough research funding has been put into it yet. In regards to the other components, we follow evidence-based interventions. One of the most evidence-based interventions for any stimulant use disorder, whether it be cocaine or methamphetamines, is actually contingency management, and we do that. So we really, again, we'll take anybody with any chemical use issues, substance use disorders. We'll address it in that 3-component plan. We will provide things that are best evidence-based or within the best of our abilities. And we do have a lot of different interventions. A lot of people say, well, there's no treatment for it. That's just not true at all. And then we'll, move along in addressing other correlated issues. And I'll finish by saying almost every patient we have uses more than one substance. So it is a fallacy that patients have opioid use disorder alone. And I don't even mean their mental health conditions. I mean, people also drink, also smoke marijuana. They may switch to methamphetamines if they're using a particular medication. There's a higher prevalence of that than using some of the medications because of the way that they operate in the brain. But that's the stuff that we do, and we address them in that holistic model, regardless of their singular focus use or more often multi-use. Dr. King, any thoughts?
Yeah, and that is a good description of the current state as it pertains to medication treatment. But going back to what Dr. Ryan said at the beginning, individualized treatment plan involves all 3 of those core components of treatment, right? So our psychosocial treatment program can be still quite powerful for patients. So we utilize contingency management. We still offer counseling and therapy. And if there's a period of time where we can engage the patient in counseling, then sometimes our medical providers can then think about using some medications on an off-label basis. So in a lot of ways, we're managing a patient's co-occurring or concomitant use. We're providing the comprehensive treatment model as it pertains to those aspects of their clinical presentation. Specifically for the stimulant use, we add some elements around contingency management and reinforcement of treatment engagement, and then potentially could add some off-label medication to the overall picture. But it's a pretty comprehensive look, and it's a long-term look at the patient, as opposed to we either feel like we have some tools today or we don't, or something like that. I think sometimes the thought process around amphetamine use can feel very limited if we don't think of it in the broader lens that Dr. Ryan just described. The other thing I'll say is that sometimes folks don't even know what they're using, right? It's not like folks are walking around with a mass spectrometer in their pocket and they understand exactly what it is that they've taken or injected, right?
Yeah. Thank you, Dr. Ryan and Dr. Kang. And thank you to everyone on this call. It's been a pleasure meeting with you all today. I'd like to invite you for a tour. If you'd like to come, we'd love to show you our beautiful new facility. Here's Tashana's information. And we look forward to forming stronger and lasting partnerships with all of you in our community. We're happy to answer any questions you may have or listen to any feedback. And thank you very much for your time today. Have a great afternoon.
Thanks so much, everyone. Have a great day.
Bye-bye.